Hello students, welcome to this session. So let's study course on Hospital Infection Control Practices, HICP. Hello students, today we will have discussion on hospital acquired infection. Start with the definition. So it is also called nosocomial or healthcare associated infection. So it is infection acquired in hospital by patient who was admitted to other reason. Infection was not present at time of admission and symptoms appear after 48 hours of admission. That is called as hospital acquired infection. So that means infection getting in the hospital, acquired in the hospital. So now what are the factors which give rise to hospital acquired infection? So it is immune status of the patient. So if immunity is good, then patient will not get that hospital acquired infection. So immune status of the patient, hospital environment. So cleanliness is, if it is there, then there will not be the hospital acquired infection. Then hospital organisms present in the environment. Then diagnostic and therapeutic procedures, if they are done aseptically with proper precautions, then there will be low chances of the hospital acquired infection. Then blood transfusion. So if the screening of the blood and blood product is done properly, then the chances of the blood transfusion infection is less. And then poor hospital administration. So these are the factors which give rise to hospital acquired infection. Then we'll see sources of hospital acquired infection. So there are mainly two sources, endogenous and exogenous. So endogenous means from inside the body. So that is a normal flora which become pathogenic and then give rise to infection. And then second source is exogenous, that is it is present in outside. So first in that it is hospital personnel. So they carry microorganisms and directly transmit it to patients. Then second is environment. So first is in that it is hospital air which contains microorganisms. Second is surfaces, so contaminated by patient secretions, blood, body fluids, excreta. So surfaces like bed or trolleys or furniture, then objects like bed, tables, trolley, furniture, then medical equipments like thermometers, stethoscopes, blood pressure apparatus, bedpan, urinals, spatula, needles, so etc. These are all used for the patient, and if they are contaminated, they may cause infection to the patient. So we'll see causative agents causing hospital acquired infections. So it is a escape group of microorganisms, that is Enterococcus, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter, and Pseudomonas aeruginosa, Enterobacter. And then other microorganisms which may cause hospital acquired infection. So they are E. coli, Mycobacterium tuberculosis, Legionella pneumophila, then Candida albicans, Clostridium difficile, which causes diarrhea. Now we'll see mode of transmission of hospital acquired infection. So in that, contact, inhalation and other things are there, other mode are there. So first is contact, so it can be direct contact or indirect contact. Then inhalation, so it can be droplet. So if more than 5 micron size of the droplet is there, so that can cause in infection. And then airborne, when the size of that source is less than 5 micron. Then bloodborne, so can be because of the blood or blood products through transmission, which causes disease like HIV, hepatitis B and hepatitis C. Then next is vector-borne, so vectors can be mosquito or flies. And then common vehicle like water, food, equipments contaminated. So these are all mode of transmission of hospital acquired infection. Then we'll see types of hospital acquired infection. So here there are divided into major types and other types. So major types, it can be catheter associated urinary tract infection, central line associated bloodstream infection, ventilator associated pneumonia or surgical site infection. And then other types, it can be transfusion associated infection, healthcare associated gastroenteritis or healthcare associated tetanus. Other types of HI, so transfusion associated infections like HIV, hepatitis B, hepatitis C. So risk of infection through blood and blood products.
So first is the definition. So it is presence of significant bacteriuria in catheterized patient with or without symptoms or signs referable to urinary tract. So significant bacteriuria means colony count should be more than 10 raised to 5 colony forming units on blood agar plate, and with or without symptoms. So if it is with symptoms, it is called significant symptomatic bacteriuria. If it is without symptoms of urinary tract like hesitancy or frequency, burning micturition, or dysuria, that is pain at the site of urination, fever. So if without symptoms, it is called as asymptomatic bacteriuria. So now we will see what are the causative agents, microbiological agents causing catheter associated urinary tract infection. So if the catheter is placed short term, then it is monomicrobial, that is single organism is involved, and it may be more prominently E. coli, and then other bacteria like Klebsiella, Serratia, Citrobacter, Enterobacter, Pseudomonas, Acinetobacter, cons, that is coagulase negative staphylococcus, enterococci, candida is a fungus. So these are seen in short term catheterization. If long term catheterization, then it is polymicrobial, that is many organisms are present at one time, and they may be these short term organisms plus other organisms like Proteus, Providentia, Morgagni. Now we will see pathogenesis. So there are mainly 4 entry points to cause the catheter associated UTI. So first it is urethral meatus and catheter junction. Then second is the drainage tube and bag junction. Third is the entry present in drainage bag, and fourth is at the outlet valve of the drainage bag. Now we will see what are the factors causing urinary tract infection. So it is divided into device related, patient related, and healthcare worker related. So first we will see device related. So in that, type of catheter is very important. So which type of catheter is used, that gives the urinary tract infection. Then type of material, whether it is latex, so it is more risky. Then patient related. So female patients are more prone for the urinary tract infection. Then if illness is present, the fever or any other infection, then it is causing urinary tract infection. Old age, that is more than 50 years of age, are more predominantly involved in UTI. Then patient having diabetes mellitus, raised serum creatinine, poor hygiene of the genital tract, or incomplete emptying. So these are the patient related factors. Then healthcare worker related factors, so either doctors or sisters or paramedical workers who are inserting that catheter, maybe they are not taking proper aseptic precautions, and that may land up in urinary tract infection. So now we will see diagnosis of COTI, that is catheter associated UTI. So first is a device criteria. So in that, presence of urinary catheter in a hospital environment more than 2 days. Then clinical criteria, so any one sign and symptom of the UTI, that is fever, suprapubic tenderness, urgency, so patient feels urgent to go, cannot control urination. Then frequency, so that is increased number of the urination. And then dysuria, it is pain at the site of the urination. Then cultural criteria, so it is significant count is more than 10 raised to 5 per ml of the urine, it is called as significant bacteriuria. And then in that, treatment is removal of the catheter and appropriate antibiotics should be given. Now we will see sample collection. When we have to diagnose that, how to collect urine sample. So you have to disinfect the tube with the alcohol, and then from the proximal portion of the tube you can collect the urine sample. But urine sample should not be collected from the drainage bag. So sample can be collected from the sampling port after disinfection with alcohol. Then what are the documentation required? So first is indication of the catheterization, why this catheter is inserted. Then name of the healthcare worker who inserted that catheter, date and time, daily assessment for need of the catheterization, and daily catheter care should be performed, that is cleaning and emptying of the bag frequently, and then date of removal of the catheter if catheter is not required. Now we will see care bundle for urinary catheter. So what is bundle? So it is group of instructions. So it is called care bundle. So it is for the insertion of the catheterization. So it is catheter should be inserted only when it is indicated appropriately, then only sterile atoms, that is sterile catheter and other things used, then it should be non-touch technique with strict asepsis. So the sterile catheter is used and the part, that is periurethral part, is strictly cleaned. Then continuous closed drainage system should be used. Catheter of appropriate size should be used. Then catheter properly secured by plaster to plaster technique. So it should be secured over the abdomen or over the thigh, and then that drainage bag should be below the bladder level but above the floor level. The maintenance bundle. So daily what things we have to do? So daily catheter and meatal care, that is strict aseptic technique is used. After hand hygiene and single gloves is used for the single patient. Then catheter properly secured, drainage bag should be above the floor and below the bladder level, closed drainage system should be there, and collection of urine from the bag. So separate jug is there for the collection, hand hygiene done, gloves used, and then alcohol swab is used for the aseptic of the outlet. Then daily assessment of readiness of removal of the catheter must be documented. So if it is indicated for the removal, or if any sign of obstruction or infection, then removal of the catheter should be done. So this is a summary of the precautions taken to prevent urinary tract infection. So before catheterization, the person should know knowledge about the catheter type and size to be used, and only the where indicated, that is indication, should be there. Then during catheterization, gloves should be used, then hand hygiene and then gloves used. Then sterile catheter should be used. Periurethral cleaning should be done with proper aseptic precaution. Then catheter insertion should be done with 2% lignocaine. Then balloon inflation should be done and it is secured properly. Then gloves removed and hand wash done. After catheterization, closed drainage system properly maintained. The bag should be below the bladder level and above the floor level, and then emptying of the bag should be done after doing hand hygiene and using gloves, and separate jug should be there for emptying each bag, and then frequently it should be done. Over collection of the urine should not be there in the bag, and then separate container used, then hand hygiene, gloves used, alcohol swabs for the meatal care with soap and water should be done. So what is the definition? It is development of bloodstream infection in hospitalized patient which is attributed to presence of central line as a source of infection and not associated with any other causes of the bloodstream infection. So it is totally of the infection of the central line after the insertion. So classification of central line can be, it is short term less than 72 hours, long term more than 72 hours, or according to the site it can be subclavian, femoral, internal, jugular, peripheral vein. Organisms causing central line associated infection, they can be cons, coagulase negative staphylococcus, Staphylococcus aureus, gram negative bacilli, in that it can be Klebsiella, Enterobacteria, then Pseudomonas, Acinetobacter, Citrobacter, and in fungi it is Candida. So cons and Acinetobacter, these two organisms, and Pseudomonas, these organisms are more commonly isolated. The route of entry in this, it can be through the patient's skin flora because of not taken proper aseptic precaution, or the contamination through healthcare worker because of the no proper hand hygiene, or hematogenously from the other focus of infection inside patient's body, or contamination of the device. So risk factors are device associated, patient associated, or healthcare worker associated. So in device associated, it is dependent on the duration. So longer the duration, more is the risk. Then site, femoral site is more risky, so subclavian site should be preferred. Then type, non-tunneled is more risky, multi-lumen more risky, and emergency situation is more risky than the elective situation. Patient related risk factors, so it is immunodeficiency, patient may be on immunosuppressant, long term steroids, or patient is having immunodeficiency disorders or higher antibiotic use. Patient may be having illness, any hematologic malignancy, burn, psoriasis, or any distant focus of the infection in the body. Healthcare worker associated factors, it can be poor hand hygiene, lack of infection control practice, that is ICP, skin antiseptic which is used. So alcohol is more causing infection than the chlorhexidine. So chlorhexidine is a preferred antiseptic. So now we will see what the diagnosis. So according to the device criteria, the catheter should be more than 2 calendar days. Clinical criteria, there should be symptoms like fever, chills, rigors, hypotension, bradycardia, apnea. Then catheter site, you will see erythema, that is redness, tenderness, warm, and swelling will be there. And sample taken, blood sample taken, it will show positive culture report. Now we will see insertion bundle and maintenance bundle. So what precaution should be taken while insertion, and then after that the maintenance. So in insertion, first is proper hand hygiene with all the steps, then sterility should be maintained, sterile device, and proper antiseptic is used with maximum PPE, that is gloves, mask, cap, apron. So all these things should be required. Then site, so subclavian site is choose because femoral is more having risk factor. Then in skin antiseptic, alcohol is more having risk factor, so chlorhexidine should be used. Then skin should be completely dry. Then semi permeable dressing should be used, and date and time of insertion should be recorded. In maintenance bundle, daily care with hand hygiene and decontamination by alcohol should be done. Then local signs of infection like erythema, tenderness, warmth should be checked. Then change of dressing with 2% chlorhexidine should be done, and daily assessment of the removal of the catheter or central line should be seen. So it is pneumonia that occurs in 42 to 72 hours after endotracheal intubation or mechanical ventilation. It is characterized by presence of new or progressive infiltrate, sign of systemic infection, that is fever, increased total leukocyte count, worsening oxygen percentage of saturation, and changes in sputum character. In that culture is positive and the microorganisms isolated are commonly Pneumococcus, Acinetobacter, Pseudomonas, H. influenzae, MRSA, that is methicillin resistant Staphylococcus aureus, E. coli, and Klebsiella. So in microbiology, if it is early onset, in 4 days the bacteria are Pneumococcus, H. influenza, MSSA, and Moraxella. MSSA is methicillin sensitive Staphylococcus aureus, and if late onset, that is more than 5 days duration for the ventilator, then it is Pseudomonas aeruginosa, Acinetobacter baumannii, E. coli, Klebsiella, Serratia, and MRSA. The source may be endogenous or exogenous through air, water, equipments, or nebulization medicines. The pathogenesis is entry through the aspiration of oral gastric secretions or direct extension of infection or inhalation of aerosols, or it may be hematogenous. The risk factors are divide associated, so it is duration. If more duration, more risk for the ventilator associated pneumonia. Then re-intubation is one factor, nasogastric tube or humidifier used. Then change of ventilator circuit, aspiration, of gastric fluids or aerosols, the inhalation, intracuff pressure if it is less than 20 cm of H2O, irrational use of antibiotics, or maybe patient is having stress ulcer, antagonist, antacids, sedation or tracheostomy. So these are the risk factors associated with the device. Then patient associated factors, the age more than 60 years and males are predominant. Then duration of the hospital, more the duration more the pneumonia can happen. Then illness, like patient is having COPD, chronic obstructive pulmonary disease or ARDS. Then supine position, coma, poor nutrition, immobilization, decreased immunity, burn, sinusitis. So these are all patient related factors. Then healthcare related factors, in that improper aseptic precautions while handling the endotracheal tube or ventilator and contaminated environment. So diagnosis can be mechanical ventilator should be more than 2 days. Then symptoms, anyone like fever, hypothermia, leukocytosis or leukopenia, and culture is positive from the respiratory secretions. So these are the diagnostic criteria for ventilator associated pneumonia in hospital acquired infection. Then prevention should be, hand hygiene should be done, elevation of head 30 to 45 degree to prevent aspiration. Then oral care with chlorhexidine, that is 2% solution, should be used. Peptic ulcer prophylaxis can be by sucralfate only. Then deep vein thrombosis prophylaxis should be done, and daily assessment for the removal of the ventilator or endotracheal tube should be done. So it is infection that develops at surgical site within 30 days of surgery or 90 days of surgery of breast, cardiac or joint. The microorganisms are most commonly identified are or isolated are Staphylococcus aureus, gram-negative bacilli and anaerobes. The diagnosis is purulent pus from the surgical site or local signs of infection, and culture positive from discharge collected from the surgical site. The risk factors procedure wise, so improper surgical scrub, inadequate skin antisepsis, prolonged operation time, inadequate antimicrobial prophylaxis, poor peri-operative glycemic control, emergency procedure, pre-operative shaving. Then according to the patient criteria, age more than 60, malnutrition, diabetes mellitus or other comorbid conditions, then low immunity, MRSA carrier, duration in hospital is more, smoking, obesity, history. Then organism wise, it is bowel surgery, bacteria, viruses form biofilm. Then environment, so positive for blood clots, sutures, foreign bodies, contaminated medicines, inadequate ventilation. Classification of wound is of 4 types: class 1, class 2, class 3 and class 4. So in class 1 it is a clean wound, there is no inflammation, that is sign of inflammation like redness or swelling or temperature, no hollow viscous entered. Class 2 clean contaminated wound, hollow viscous entered. Class 3 contaminated wound, no purulent inflammation plus necrotic tissue. Then class 4 is dirty infected wound and there is sign of active infection. Classification of SSI, superficial SSI, that is skin and subcutaneous tissue involvement, and it is within 30 days. Deep SSI, muscle and facial layer is involved and it is within 30 days. And organ and space SSI, that is organ space is involved within 30 days. So prevention of SSI, so first is pre-operative prevention. So in that pre-operative bathing of the patient should be done with help of antimicrobial soap. Then MRSA carrier for the patients, then mupirocin ointment is used. Then hair removal should be done by clipper, not shaving is not done. Intraoperative, So SAP, that is surgical antimicrobial prophylaxis, is there. So it is should be given 60 to 120 minutes before incision, and antibiotics used can be cefazolin or cefuroxime. Then single dose should be there, or if surgery is more than 4 hours or surgeries like cardiac surgery or where extensive blood loss is there, dose can be repeated. Then surgical hand disinfection with antimicrobial soap or chlorhexidine or alcohol based hand rub should be there. Then surgical site preparation, it should be by alcohol based chlorhexidine or antiseptic solution used for the surgical site preparation. Then perioperative, there is maintenance of the oxygen, that is 80% FiO2. Temperature should be normal. Blood sugar level should be less than 200 milligram percent. Normovolemia and nutritional support should be there. In post-operative wound dressing, daily with hand hygiene and gloves. So while doing dressing, hand hygiene should be done first, and then gloves wear, and then the dressing should be done. Then OT disinfection should be there with high level disinfection in surgery and in between surgery and at the end. Then periodic monitoring of air quality in operation theatre. There is no air exchanges. Temperature, humidity, pressure, microbial contamination all should be monitored. And then prolongation of the antibiotic prophylaxis is not recommended because of the antibiotic resistance. Hello students, welcome to this session. So chapter 16. So in that, universal or standard safety precautions, and in detail we will study hand hygiene. So in universal standard safety precautions, what are these and what are the components of that, like hand hygiene, biomedical waste management, protective equipments, injection safety and all. So these components we will see, and we will see hand hygiene in detail. So first, universal safety precautions. So these are a set of infection control practices used to prevent transmission of diseases that can be acquired by contact with blood or body fluids with non-intact skin or mucous membranes. The components are hand hygiene, personal protective equipments, biomedical waste management, injection safety, routine environmental cleaning, disinfection, then spillage cleaning, respiratory hygiene, appropriate handling of the linen. So these are few important components of the precautions. So let's study hand hygiene in detail. So hand hygiene is washing of hands promptly after contact with infective material. So there are different types of hand wash. So first is social hand wash. It is a common practice we do after using washroom or before the meals. Then second is hand rub. So here it is a use of alcohol based sanitizer. Then hand wash. So it is when the hands are spoiled. So that time we use antimicrobial soap, or then ordinary soap if the antimicrobial soap is not available. And then duration of this is longer than the hand rub, that is 40 to 60 seconds. And then surgical hand wash, before the surgery we do hand wash up to elbow. So this chart shows the types of hand hygiene, then which agents we use, what is the purpose, area and duration. So routine hand wash, the first one. So in that we use usually soap and water. Purpose is to remove soil and transient microorganisms. So area used is hands and fingers. And then duration is minimum 15 seconds. Antiseptic hand wash. So here we use water and soap. Antimicrobial soap can be composed of chlorhexidine, iodine, iodophore, chloroxylenol. Then the purpose is remove or destroy transient microorganisms and reduce resident flora. So all surfaces of the hands and fingers, and duration is 15 seconds. Antiseptic hand rub. So it is alcohol based hand rub, that is sanitizer. So it remove or destroy transient microorganisms and reduce resident flora. And same hands and surfaces of hands and fingers, and until hands are dry. A surgical hand wash is use of antimicrobial soap and water. It removes or destroy transient microorganisms and reduce resident flora. The area mainly it is different. So here it is surfaces of hands, fingers and up to elbow, forearm. So duration is longer, minimum is 2 to 6 minutes. So here you can see the steps of hand wash. So here For the hand rub, when we are using alcohol based sanitizer, so total steps are 7, and for hand wash, when we are using water and soap water, then it is, or liquid soap, then it is total steps are 10. So first you have to apply hand rub or liquid soap or soap. Then in step 2 you have to rub palm to palm. Then in step 3 back of the palm both the sides. Then step 4 between web spaces of the fingers. Then step 5 back of the finger on the palms both sides. Then thumb in rotational movement both the sides. Then step 7 you have to scrub your nails on the palms both sides, and then this is for the hand rub. So for the hand wash, now you have to rinse hands with water, then dry with single use paper towel or tissue paper, and then close the tap with elbow if the handle is there, or with the tissue paper, and then let it dry. So after use of tissue paper. So these are the steps. So first 1 to 7 steps are for hand rubs, and 1 to 10 steps are for the hand wash. So these are 5 moments of the hand wash: before patient, before touching patient, before any technique, then after contact with blood body fluid, after touching patient, and after touching patient surroundings. So these are 5 moments of the hand. So the aim of PPE, that is personal protective equipment, is to determine the equipments to use for a given procedure. The healthcare workers should consider the following factors. So they should know the factors where to use and which personal protective equipment to be used. So what is the probability of exposure to blood and body fluids, or type of body substance involved, and probable route of transmission of infectious agent. So transmission of infectious agent by inhalation, or by direct contact, or by indirect contact. So this is important. So for direct contact we will use mainly gloves, and for inhalation purpose the main PPE is, that is mask. So depending on the exposure, type of body surface involved, and transmission of the route of the infectious agent. So these are the factors. So full protective wear including double gloves, protective eye, face shield, protective footwear, gown and apron is recommended for operating room or mortuary procedures. So PPE are used to protect skin and mucous membrane of healthcare worker from exposure to blood and body fluids, and from HCV to patient, that is from healthcare worker to patient during the procedures. So it is to and fro procedure. So transmission of infection from patient to healthcare worker, from healthcare worker to patient. So to prevent this we have to use personal protective equipment, so for the safety of the patient and for the safety of the healthcare worker. So the contents are gloves. So when you're touching blood or equipments, invasive procedures, you have to use gloves, gown or plastic apron while surgery, surgical mask or N95 mask while surgery, droplet or airborne infection, cap, face shield, goggles when the major is spillage of blood or body fluids expected, and surgical shoes in ICU or operation theatre. So first is gloves. So use of disposable gloves is part of the standard precaution. The uses are as part of personal protective equipment. Gloves prevent contact with blood and body fluids and mucous membranes. They also protect patient from contamination by microorganisms from the healthcare workers' hands. So gloves are single-use items and changed after each procedure to further minimize the risk of infection. So separate pair of gloves is used for the separate procedure or for the separate patient, and for the same procedure patient, if the gloves are spoiled, then you have to, for the same patient also, you have to change the pair of gloves. So gloves are worn when dealing with blood or body fluids such as synovial fluid, peritoneal fluid, amniotic fluid, pleural fluid, any wound or broken skin, handling chemicals or disinfectants. So while handling chemicals and disinfectants, we can use domestic or industrial gloves. Second is gowns or apron. So purpose of wearing gown and apron is to protect susceptible patients from infection and protect the healthcare worker from contamination. So, and it is a uniform or clothes they used in a clean and dry state. So gown and apron should not be worn outside the area they are intended to be used. Remove gown and apron when moving out of area. Then face protection. So protective eye or face wear are considered where risk of blood and body fluids splashing into the eyes the possibility. So or while preparation of cytotoxic or chemotherapy drugs, and then during the physical decontamination or cleaning of the instruments. Then mask. So mask offer protection against potential splashing of the mouth and face during certain procedures such as minor operation, physical decontamination or cleaning instruments with a brush. So there are two types, surgical mask and N95 mask. So surgical mask mainly used for during surgical or dental procedures, and N95 mask were mainly used attending the patients with acute pulmonary tuberculosis or nowadays the pandemic of COVID-19. So now what are the precautions? So they should be fitted and worn according to the instructions, not touched by hand while being worn. Then cover both mouth and nose, should be removed as soon as possible if they become moist or spoiled, and removed by touching the straps, not by touching the mask. And then hand hygiene should be there after removing the mask. Shoe cover before entering the ICU, operating theatre, dialysis or CSSD room. Then protective footwear. Again, footwear is also important to protect legs from the sharp injury. Then head cap covers the hair of the healthcare provider in order to prevent the contamination of sterile high risk areas. So here you can see these personal protective equipments used by this person. So eye protection, then face mask, gown, and then shoe cover. So now how to wear that? It is called as donning of the PPE. So wearing of PPE is called donning, and removing of the PPE is called doffing. So the main sequence for donning is first to wear gown, then mask, then goggle or face shield, and then in the last gloves. Doffing, so while removing, first you have to remove the gloves because they are soiled. So first you have to remove the gloves, then goggle or face shield, then gown, and then in the last mask. The rational use of gloves. So how to wear gloves? So first you have to use your dominant hand, then with help of first hand hygiene is important. After that dry your hands and then put your one dominant hand inside the one glove, then with help of second glove you can use with the gloved hand, and then use the another hand, then insert and then wear it properly. So while removing, pinch and hold the outside of the glove near the wrist area, then away from the wrist, turning the glove inside out, then roll it in a gloved hand. Then in fourth step you have to put your ungloved hand inside the gloved hand with help of fingers. Do not touch the outer surface of the glove because now your next other hand is ungloved. Then peel downwards away from the wrist, turning the glove inside out, and then continue to pull the glove down and over the inside out glove being held in your gloved hand. So the one first glove you have to put inside the another glove and then put it in a bin. And then hand hygiene. Now how to wear mask. So in mask, in this picture you can see these total 6 steps. So how to wear a mask. So first you have to do hand hygiene, then wear mask by holding straps, then pinch to ensure no gaps are left, and then secure properly underneath your chin and then over the nose tightly. How to remove mask. Wash hands thoroughly. Remove mask by holding the strap, then discard single use mask. Wash your hands again. So what is respiratory hygiene? So while coughing, sneezing, we should use of tissue paper, or we should do it in our inner elbow, so that it is not forming aerosol or droplets and then not contaminating or transmitting that infection to other persons in that area, the hall or the theater, or where the crowded place is there. And then hand hygiene should be done after contact with the respiratory secretions. Cover nose, mouth with mask while surgical mask or N95 mask. So respiratory hygiene and cough etiquette. So the strategy is targeted at the patients and accompanying family members and friends with undiagnosed transmissible respiratory infection, and then this applies to any person with signs of illness including cough, congestion, rhinorrhea, that is running nose, or increased production of respiratory secretions while entering a healthcare facility. So if anyone is having symptoms like cough, sneezing, or sputum production, then that person should take precautions. So what things they should know in cough etiquette? So the education of healthcare staff, patient and visitors should be they should know about the respiratory hygiene. Then they should cover the mouth or nose with tissue or cloth while coughing and sneezing. Then hand hygiene after contact with respiratory secretions, they should maintain distance minimum more than 3 feet for respiratory infection in common meeting areas. Then mask should be provided to coughing patients. Then healthcare personnel are advised to observe droplet precautions, that is wearing mask, hand hygiene while examining the patient. Then they should be advised to avoid direct contact with the patient, especially high risk patient, and then they should wear mask while taking care of the patient. So in spillage cleaning, you should wear gloves and gown. Wipe up the spill immediately with absorbable material. Wipe that area with 10% sodium hypochlorite. Then remove your PP and perform hand hygiene. So in spill kit, what things should be available in high risk area like laboratory, sample collection room or wards? So in that for blood, the PP should be there of gloves, apron, mask, shoe cover and eye protector. Then absorbent material like newspaper or blotting paper, tissue paper should be there. Then water collection bag should be there. Waste collection bag should be there. Then scoop and scraper, disposable forceps, buckets, mops and signage board for the no entry till you remove that spillage. So this is a steps for the blood or body fluid exposure spillage. So in that, keep signboard first, then wear PPE, cover it with piece of paper or absorbent cloth, then pour 1% hypochlorite solution on the spill. Then for major spill, wait for 30 minutes for the action of disinfection. For minor spill, you can wait 10 to 20 minutes. Then wipe the area in a circular manner and put the collected material in a yellow cover bag. Mop the area with disinfectant. Send the incident report form to infection control nurse. Hello students, chapter 19, injection safety. So today we are going to discuss on injection, that is needles and sharps, injuries and safety precautions regarding that. So the practice to prevent transmission of infection between patient and healthcare worker during preparation and administration of injection is called as injection safety. So needle stick injuries are puncture wounds, cuts or scratches inflicted by medical instruments intended for cutting or puncturing like cannulae, lancets, scalpels that may be contaminated with patient's blood or other body fluids. Contact of blood with non-intact skin and contact with mucous membrane like eye, mouth and nose are also included under the term needle stick injury. So potentially infectious specimens are blood, genital secretions and all body fluids like pleural fluid, peritoneal fluid, cerebrospinal fluid, synovial fluid and other specimens contaminated with visible blood. Potentially non-infectious specimens are feces, nasal secretions, saliva, sputum, sweat, tears, urine, vomitus unless they are contaminated with blood. So if they are free from blood, then they are potentially non-infectious as compared to the blood and contaminated blood specimens. The activities associated with needle stick injury are: while handling or transferring specimens, improperly disposed shafts, recapping of the needles, hand passing needles or shafts after use, during cleaning procedures, or in surgery, like passing of needles and shafts in surgery. Factors for needle stick injury. So it is type of needle. So hollow bore needle is of high risk. Devices visibly contaminated with blood, they are high risk. Depth of injury, volume of blood, viral load, delay in first aid, delay in post exposure prophylaxis, reuse of syringe, overuse of injections, unsafe shafts waste management, mishandling of improperly secured body fluid containers, working in rush and under stress. So this is also very important point. If you are working under stress, then chances of accidents are more. Then prevention of needle stick injury. So first is precaution during handling the needles or shafts. So first is hand hygiene. So you have to do hand rub or hand wash with either sanitizer or with the antimicrobial soap. Then proper wearing of the personal protective equipments. So very important is gloves, and then the apron or face mask. Then work surface disinfected with 10% sodium hypochlorite solution. Whatever procedure you are doing, that is catheterization, taking sample, giving injection, so there should be aseptic technique, that is the part of the patient is cleaned with the proper disinfectant. Then only you do proper sterile materials should be used. So proper aseptic technique should be there. Then disposable syringes and needles should be used. So reuse of the syringes and needles is not advised. So whatever syringes, needles, scalpels, vein flow or catheter, whatever thing we are using, that should be disposable. So only one use and then throw that. So throw in a proper container. The needles are not reused. Previously, few years back, doctors or paramedical workers used to use needles after boiling with water, but then proper time and proper sterilization not completed, and then there were the chances of the transmission of infections like HIV, hepatitis B, HCV. So needle syringes are not reused. Needles should never be capped. So that while capping also there are chances of accident. So no capping of the needles. Needle and shafts not left on trolleys and bedside tables. So they should not be left on a trolley without putting them in disposable container. Disposal of used needles. Needles disposed into sharp box immediately after use. Use of vacutainers for blood collection. So preferably vacutainers should be used for blood collection. Medical vials should be cleaned with 70% alcohol. Medication should never be administered from same syringe to multiple patients, even if different needle used. So this is very common practice in general practitioners, but then there are also chances of transmitting infection. So same syringe should not be used for the many patients, even if different needle is used. So many times it happens, we see that the needle is put in a syringe is put in a antibiotic solution, and then only needle is changed, and then the doctors are giving injections to many patients from the same syringe. This should not happen. Intravenous set should never be used for more than one patient. Spillage of blood and body fluids should be cleaned thoroughly with 10% sodium hypochlorite solution. Minimize use of injections. So wherever necessary, oral drugs should be prepared and advised. So invasive procedures, injection should be deferred. Healthcare workers should be vaccinated with 3 doses of the hepatitis B vaccine, that is first dose, then second dose after 1 month, and third dose after 6 months. So 016. So hepatitis B vaccine is available, so every healthcare worker should be vaccinated, because for other HIV and other HCV vaccines are not there, but what vaccine we are having, that we should use. So precautions during surgical procedures. So many accidents happen because in surgery many sharp objects are used like scalpel, blade, forceps, needles for suturing and all. So precautions are very important. Then sharp instruments should be passed on by non-touch technique, not directly by hand to hand. So they should be kept on some tray over the some green cloth, and then they should be passed to the surgeon. So suturing needle holder should be used for the holding needle while suturing. Pre-operative investigation should be done, HIV, hepatitis B and HCV. Then blood-borne viral infections, positive patient, in that use of double gloves should be there, trained staff should be there, and case posted late in the list. After that case, decontamination of OT should be done, and surgeon should wear proper personal protective equipments including double gloves. So injection safety, practice to prevent transmission of infection between patient and healthcare worker. Hello students, today we will study about transmission based precautions. So what are the types? They are contact transmission, droplet transmission and airborne transmission. So what are the causes and what we have to do for that? So what are the precautions? So first is contact transmission. So where it can happen? So respiratory droplet settles down on floor and surfaces, inanimate objects, any one of at a later stage when touches the floor, surfaces, door handles, inanimate objects, etc., and then touch face, nose, mouth, eyes, virus can easily spread. So here you have to take proper precaution, that is hand hygiene, the most important precaution. Then second is the droplet transmission. So it can happen where the respiratory droplets produced when the infected person coughs or sneezes can infect the persons by sitting on their mouths, noses or eyes who are within 1 meter distance. So the most important precaution here is a surgical mask if within 1 meter of the infected case. Then third one is the airborne transmission. So airborne transmission from person to person over long distances is unlikely. So aerosol generating procedures like during aerosol production in tracheal intubation, open suctioning, non-invasive positive pressure ventilation, tracheostomy, cardiopulmonary resuscitation, manual ventilation before intubation, bronchoscopy, airway suction, chest physiotherapy, nebulizer treatment, sputum induction, collection of specimens, or in laboratory when we are doing centrifugation, transferring sample from one place to another. So these are the situations where we can get airborne transmission and of the organisms, and the most important precaution here we have to use the mask, that is N95 mask. Now we will see what are the causative organisms. So for standard precautions, organisms are cytomegalovirus, HIV, hepatitis B, C, aspergillus. In contact precautions, the organisms are MRSA, then VRE, vancomycin resistant enterococci, adenovirus, diarrhea producing Clostridium difficile, rotavirus. So these are the organisms. In droplet, pertussis, influenza, Neisseria, Coxsackie, bacterial meningitis, mumps, rubella. In airborne, it is chickenpox, then measles, tuberculosis, SARS, and avian influenza. So now we will see in detail. So first one is contact transmission. So it can be of two types, direct and indirect. So indirect, it is through the contaminated hands with blood and body fluids. Indirect, from the clothes, patient care devices or environmental surfaces like floor touching the door, handle of the door, and etc. The agents are most commonly are methicillin resistant Staphylococcus aureus, Acinetobacter, Pseudomonas, adenovirus, chlamydia, group A streptococcus, staphylococcus, rotavirus, vibrio, Clostridium difficile. So precautions here. So most important step, first one is the hand hygiene. Alcohol based chlorhexidine mixture of the A sanitizer should be used for the hand rub or hand wash. Then personal protective equipments like gloves, surgical mask. Then single use uh, patient dedicated equipment should be there, and patient should be placed in isolation room, or cohorting can be done. So cohorting means when the same the group of symptoms if present in many patients, then they can be kept in a room together. So the space should be more than 3 feet. With the curtains you can isolate the patient. Second one is the droplet infection. So when it can happen, so respiratory droplets are more than 5 micrometer in size. So during cough, sneezing or talk, these droplets can spread the infection. So agents most commonly are diphtheria, the Corynebacterium diphtheria, H. influenzae type B, meningococci, pertussis bacteria, then plague, mycoplasma, streptococcus and influenza. The precautions we have to take here is first hand hygiene, alcohol based or chlorhexidine based, then personal protective equipments, healthcare workers should wear surgical mask, respiratory hygiene and cough etiquette, that is proper cough procedure using clean cloth or tissue paper, and while coughing you should cover your mouth and nose. Then patient placement, it should be in isolation room. Coating can be done, so space should be more than 3 feet with the curtains applied for the separation in between patients. Then patient should wear surgical mask in transport, and then healthcare workers should wear the surgical mask, and disinfection of the room is there while discharge of the patient. Now third type is airborne transmission. So in that aerosols less than 5 micrometer in size are produced during cough, sneezing or talk, and then it can be produced in procedures like endotracheal intubation, tracheostomy, sputum induction, bronchoscopy, and the microorganisms responsible for this is Mycobacterium tuberculosis mainly, then measles, varicella, SARS-CoV, COVID-19, MERS-CoV, smallpox, anthracis and aspergillus. So precautions, the first most important step is hand hygiene with alcohol and chlorhexidine used in that. Then PPE, healthcare workers should wear N95 mask or high level respirator, and it should be tested whether it is fit or not. Then respiratory hygiene and cough etiquette should be followed, like while coughing or sneezing you have to cover your mouth and nose with help of clean cloth or tissue paper, or if it is not there then in the elbow you should cough or sneeze, so that aerosols are not produced and they are not transmitted to the environment. Then patient should be isolated in room with negative pressure. Then UV irradiation or HEPA filters should be used in that room. Then patient should wear surgical mask, and disinfection of the room is there after the discharge of the patient. Visitor and staff should be entry is restricted, and if they are visiting then they should wear PPE, that is mask, clothes and apron or gown. So in airborne transmission, patients are placed on airborne precautions when they have known or suspected infections transmitted over long distances through the air. So organisms mainly are Mycobacterium tuberculosis, measles virus and varicella zoster, that is chickenpox virus. So airborne infection isolation room, AIIR. So ideally patient should be placed in that room. Remember, this is room specifically designed with a special air handling and ventilation system to prevent transmission of airborne infection. So it should include negative pressure, that is air flows from corridor to inside the patient room but not from patient room to outside, and 6 to 12 air exchanges per hour. So direct exhaust of air to the outside, away from places where people walk or congregate, and at any intake openings. A door kept closed when not required for entry and exit.
Hello students, let's study sterilization and disinfection. Sterilization process by which all living microorganisms including viable spores are either destroyed or removed from an article or from the surface medium, results in the reduction in more than 10 to 6 logs colony forming units of microorganisms and their spores. Disinfection process that destroys or removes most of, if not all pathogenic organisms, but may not destroy bacterial spores. So result is reduction in 10 raised to 3 log CFU in most organisms and not spores, achieved by physical agent or chemical agent, usually used only in inanimate object, not on body surfaces. Factors for efficacy of sterilant or disinfectant: organism load, nature of organism, concentration of the disinfectant, contact time, temperature stability and relative humidity, biofilm which prevents the entry of disinfectant. Or property of ideal disinfectant is a broader microcidal activity, fast acting, not affected by environmental factors such as organic matter, non-toxic, compatible with surfaces, odorless or pleasant odor, economical and environmental friendly. The Sterilization, which kills all bacterial spores, tubercle bacilli, non-enveloped viruses, fungi, vegetative bacteria, enveloped viruses. So examples are the physical methods: steam sterilizer, that is autoclave; dry heat sterilizer, that is hot air oven; filtration; radiation, ionizing and non-ionizing; others like incineration and microwave. In chemical method, ethylene oxide sterilizer, plasma sterilizer. So Spalding classification for medical devices. So critical device, that is high risk. So items that enter normally sterile sites. So recommended method is sterilization, and the medical instruments like surgical instruments, implants, prosthesis, rigid endoscopes, syringes, needles. Semi-critical device, intermediate risk. Items in contact with mucous membrane or body fluid. Recommended method is disinfection, high-level disinfectants. Examples are respiratory equipment, non-invasive flexible endoscopes, bedpans, urine bottles. Non-critical, low-risk item in contact with intact skin. Disinfection, intermediate or low-level disinfectant. The examples are non-critical patient items, non-critical environmental surfaces. Hello students, let's study moist heat. So in that we will see autoclave in detail. So it also called as steam sterilizer. The principle: when water is heated in closed container, it produces vapor and then it causes vapor pressure. Then when water boils in closed container, the vapor pressure is increased more than the atmospheric pressure, and then it has a more penetrating power to kill the organisms. And the mechanism: killing of organisms by irreversible coagulation, denaturation of enzymes and proteins. The types of autoclave are horizontal when it is in large volume, and it is mainly used in CSSD department. And the vertical one is in small volume, used in most laboratories. The components: there are three main components: pressure chamber, lid and electrical heater. So pressure chamber is consists of the large cylinder, either vertical or horizontal. It is made up of metal or stainless steel, and it has a steam jacket, that is water compartment at the bottom. The lid: it has discharge tap for passage of air and steam, pressure gauge for the pressure measurement, and safety valve to remove the excess steam. An electrical heater: it is attached to the jacket that heats the water to produce steam. The working procedure: the materials to be sterilized are placed inside the cylinder. A steam jacket is filled with sufficient water, and then lid is closed with the help of clamps, and the electrical heater is put on. Now there are three phases. So first is conditioning phase, second is exposure phase, and third is the exhaust phase. So in conditioning phase, you have to give condition of temperature, pressure and time. That is temperature 121 degree Celsius, pressure 15 lbs and time 15 minutes. So after the water boils, the air in the chamber is completely displaced by the steam. So the steam pressure rises and then it reaches to the desired level, that is 15 lbs pressure. Then the safety valve opens and excess steam is removed out. Exposure phase, the holding period is for 15 minutes. Exhaust phase, so after the holding period is over, the electrical heater is switched off and the steam sterilizer is allowed to cool till it reaches the atmospheric pressure, and then the material inside is removed. The care and maintenance of the autoclave. So we have to always put water in steam jacket. Do not forget to put off gas burner after the holding period is over. Never leave autoclave unattended when pressure is rising, and never open the lid immediately after heating period is over. So we have to allow it to cool and then open the lid. Sterilization control, physical conditions like temperature, time and pressure, chemical indicators like external pack control, that is autoclave tape, or Browey test or internal pack. The biological indicator, spores of Geobacillus steothermophilus are the best indicator which kill spores, in which the spores are killed in 12 minutes at 21 degrees Celsius. Uses of autoclave. So there are mainly two uses: hospital uses and the laboratory uses. In hospital uses, the sterilization of surgical instruments, anesthetic equipments, dental instruments, implanted medical devices, surgical drapes and linen, biomedical waste treatment for disposal. Laboratory uses, sterilization of glassware, test tubes, slides, pipettes, petri dishes used in the laboratory, sterilization of culture media for preparation, inoculated infected culture plates, killing of microorganisms and the spores. Flash sterilization, it is modification of conventional steam sterilization used for the emergency or during unplanned procedure. So it involves fast sterilization, that is temperature 134 degrees Celsius for 3 to 10 minutes. So for surgical instruments in unwrapped condition in steam sterilizer located close to the operation theater, and it is restricted for emergency situation. Disadvantage, not suitable for porous or cannulated instrument or implants because the instruments are not packed, so they remain wet following sterilization and there is high risk of recontamination. Right. So in that examples of flaming, holding instruments to be sterilized in flame of the spirit lamp or Bunsen burner. Example, wire loop, points of the forceps, spatula, scalpel, needle, mounts of culture tubes, glass slides. Second method is incineration. It is physical method of sterilization in which material to be disposed of are kept in big dig and are burnt off. It is called incineration. It burns, that is sterilizes the anatomical waste and microbiology waste by providing very high temperature 800 to 1200 degrees Celsius, converting the waste into ash, fuel gas and heat. Uses in this is excellent method for rapidly disinfectant material such as soil dressing, infected dressing, bedding, pathological material, disposable syringes, gloves, hospital waste, lab waste, etc. Disadvantage, plastic material emits clouds of the black. The third example in dry heat is the hot air oven principle. When electricity is passed through heating coils, electrical energy is converted into heat energy. The temperature is 160 degrees Celsius and holding time is 2 hours. Uses, dry sterilization of syringes, needles, drying of glass waste, test tubes, petri dish slides, pipettes, heating of chemicals used for preparation of standards, sterilization of oil, grease, liquid paraffin. Sterilization control of the hot air oven, biological indicator, the spores of Bacillus atrophius. The uses of hot air oven, sterilization of egg media, sterilization of serum media, sterilization of sugar media. Filtration. So filtration acts by removing microorganisms, not by killing. There are two types of filters. Depth filter used as drinking water purifier. Membrane filter widely used in hospital. Bacterial filter size is pore size is 0.22 micrometer. Filtration of air, surgical, three-ply mask and respirators. HEPA filters, high efficiency particulate air filter, removes 99.7% of particles that have size of zero point 0.3 micrometer or more. ULPA filters, ultra low particulate penetration air, removes 99.999 particles that have size of 0.12 micrometer or larger. Filtration of liquid used for bacteriological examination of water in hospital settings, dialysis water to remove bacteria from pharmaceutical fluids that are heat labile and cannot be purified by any other means. Radiation, ionizing and non-ionizing radiation. So ionizing radiation include cobalt 60 gamma rays or electron accelerators. Use low temperature sterilization method that has been used for a number of medical products, tissue for transplantation, pharmaceuticals, medical devices. Mechanism causes ionization of molecules in organisms leading to breakage of DNA. Advantage, high penetrating power and rapidly acting. Temperature is not raised, so it is also called cold sterilization. Disadvantage, high sterilization cost and may have deleterious effect on equipment made up of polyethylene. Sterilization control, efficacy of ionizing radiation checked by Bacillus pumilus. Non-ionizing radiation, infrared radiation technology, alternate method of sterilization for selected heat-resistant instrument. Ultraviolet radiation does not achieve sterilization described under intermediate level disinfectant. Test for sterilizers, the indicators, physical indicator, time, temperature, pressure. Chemical indicator, they use heat or chemical sensitive material which undergo color change if the sterilization parameter, that is time, steam, quality, temperature for which it is issued is achieved. Common types are class 1, class 2, class 4 and class 5. Biological indicators, most reliable indicator as it uses bacterial spores to check the effectiveness of sterilization. Spores are highly resistant and will be destroyed only when the effective condition is achieved. Geobacillus stereothermophilus for heat sterilizer, gas plasma hydrogen peroxide and liquid acetic acid sterilizer.
Disinfection is the process that destroys or removes most of the pathogenic organisms but may or may not be the spores. So it is achieved by physical or chemical agents. So classification of chemical agents. So first type is alcohol group, that is examples ethyl alcohol, isopropyl alcohol, aldehyde, formaldehyde, glutaraldehyde, halogens, iodine, chlorine, phenol, cresol, lysol, chlorhexidine. Oxidizing agents, hydrogen peroxide. Dyes may be malachite green, crystal violet. Metallic salts of silver, copper, mercury. Gas sterilization by ETO, ethylene oxide, or plasma sterilization. Now let's see the level of sterilant or disinfectants according to their microbiological actions. So these are the 5 factors for the microbiological actions on vegetative bacteria, bacterial spores, tubercle bacilli, fungi, enveloped viruses and non-enveloped viruses. So sterilant is kills all the forms of the microorganisms. Then in disinfectants there are 3 types: high level, intermediate level and low level. So high level disinfectants kills all the morphological forms of the organisms except bacterial spores. Intermediate level do not kill or destroy bacterial spores but they can damage all the microbiological forms. Low level, they do not kill bacterial spores and fungi plus minus, non-enveloped viruses plus minus. Factors influencing the efficacy of the disinfectant. So it is organism load, nature of the organism. So example, prions or bacterial spores are highly resistant than the other microorganisms like mycobacteria, viruses, fungi or vegetative bacteria. Then concentration. So optimal concentration is required. Then contact time, temperature, stability, relative humidity, biofilm formation which prevents entry of disinfectant. So these are all the factors. An ideal disinfectant should be broader microcidal activity, fast acting, not affected by the organic matter, non-toxic, then compatible with the material, odorless and economical. The antiseptics is a type of disinfectant which is safe to apply on the body surface, that is skin and mucosa, which results in the destruction of the organisms. Then cleaning or decontamination is the reduction in the pathogenic microbial population to a level at which items are considered as safe without protective attire. Spaulding's classification of medical devices. So they are categorized into the critical device, high risk, semi-critical device, that is intermediate risk, and non-critical device, that is low risk. So critical device is item that enter a normally sterile site. So they are invasive. The examples are surgical instruments, implants, prostheses, rigid endoscopes, syringes, needles. So the recommended method is sterilization. Semi-critical device, they are in contact with the mucous membrane or body fluids but they do not enter. So they are respiratory equipments, non
non-invasive flexible endoscopes, bed pans, urine bottles. So the recommended method is disinfection, that is high level disinfectants. Non-critical or low risk devices, they are in contact with the intact skin. So non-critical patient items like an environmental surfaces. So the method of recommendation is the disinfection, that is intermediate level or low level disinfection. Agents used in the hospital for achieving sterilization, disinfection and cleaning. So they are divided into the high level, intermediate level, low level and agents of the cleaning. So high level disinfectants, the examples are aldehydes, in that formaldehyde and glutaraldehyde, peracetic acid and hydrogen peroxide. Intermediate level disinfectants are alcohols, example ethyl alcohol, isopropyl alcohol, phenols, then cresol, lysol, halogens, iodine and chlorine. Low level disinfectants, quaternary ammonium compounds and chlorhexidine. Agents of cleaning are enzymatic solution, detergent, soap, either antimicrobial or plain soap. So let's see the disinfectant. So first is high level disinfectant, so capable of killing all the microorganisms plus bacterial spores. So first is the aldehyde, commonly used are formaldehyde, glutaraldehyde. So mechanism is combine with nucleic acids, proteins and inactivate them. So the formaldehyde is excellent high level disinfectant. Uses, it is largely restricted to non-patient care area for preservation of anatomical specimens, histopathological specimens and stool specimen. The fumigation of OT is nowadays practice not used. Disadvantages, it is irritating and pungent odor and potential carcinogen, corrosive, causes skin irritation and asthma when inhaled. Glutaraldehyde, so it is used for the semi-critical items like endoscopes, cystoscopes. So it is also used for aerial disinfection and cleaning, that is fogging and cleaning of floor and surfaces of the critical areas. So example bacillocid is used in the concentration 2%, it is example Sidex. Duration is 20 minutes and for spores is 10 to 14 hours. Advantages, it is active in the organic matter. Disadvantages, pungent odor, can produce eye irritation and asthma and contact dermatitis. H2O2, hydrogen peroxide, mechanism of action, it produces hydroxyl free radicals which are toxic and attack the various cell components. The uses are sporicidal, more than the 4 to 5% concentration. 3% H2O2 for the environmental surface disinfection, fogging and wound cleaning. 3 to 6% H2O2 for disinfection of the soft contact lenses, ventilator, endoscopes. Say 6 to 7.5% H2O2 as a chemical sterilant in plasma sterilization. Vaporized H2O2 used in the industrial sterilization of medical devices and for decontamination of the large and small areas. Advantages, rapid in action, non-toxic and active in the presence of organic material. Disadvantages, expensive, can cause chemical irritation, corneal damage, should be stored properly in the dark containers. Second is the intermediate level disinfectant. Example is the alcohol. So it can be used in preparations like ethyl alcohol, isopropyl alcohol, most popular alcohol in the hospitals. Action, rapidly bactericidal except spores. Action by denaturation of the proteins. Uses, alcohol mostly used in the concentration of 60 to 80%, can be used as the hand rub, example sterilium. Disinfecting smaller non-critical instruments like thermometer, small medical items like vaccine vials or external surfaces of the equipment, stethoscope. Disinfection of non-critical surfaces, lab bench area. Disadvantages, flammable, must be stored in the cool ventilated area, evaporate rapidly, may damage the tips and lenses, inactivated by the organic matter. Second is the phenols. So phenol, carbolic acid, first widely used as an antiseptic by Joseph Lister. Mechanism of action, disruption of cell wall and cell proteins. So there are two uses, used as a disinfectant, example cresol or lysol. So it is used as a disinfection of the environmental surfaces, that is bedside tables, bed rails, laboratory surfaces, non-critical medical devices.
it is toxic to skin, so not used as a antiseptics. 5% phenol can be used for the disinfection of the sputum specimen as a mycobactericidal. Used as an antiseptic, so it is chloroxylenol. It is a active ingredient of the Dettol. So widely used as an antiseptic. And advantages, it is active in the organic matter. Disadvantages may cause hyperbilirubinemia in the infants. Third is the halogens. So iodine and chlorine are the examples. They have antimicrobial activity. So first is iodine. Mechanism is disruption of protein and nucleic acid. So there are two preparations: tincture iodine, 2% iodine in potassium iodide, and iodophore, it is povidone iodine. Example is betadine. So it is used as an antiseptic. So 5% topical solution and ointment for wound healing, 7.5% for the hand scrub, 10% for the surgical skin preparation, 1% oral antiseptics or for as a mouthwash, and as a disinfectant for the medical equipment. So it is also used in hydrotherapy of the tanks. So next is the chlorine and hypochlorite. Mechanism of action is the oxidation of cellular materials and destruction of the vegetative bacteria and fungi. So there are two preparations: free chlorine and hypochlorite. Hypochlorite is available in liquid form, that is sodium hypochlorite or household bleach, and powder form, calcium hypochlorite or bleaching powder. So uses of the free chlorine: disinfection of the municipal water supplies and swimming pool water, also in the dairy and food industries. Uses of the sodium hypochlorite: it is available in the concentration of 5 to 6%. It should be used in appropriate dilutions for disinfection of various hospital supplies. Contact time 10 to 20 minutes. Advantages: it is broad spectrum sporicidal, rapid and non-inflammable, and low cost, widely available. Disadvantages: inactivated by the organic matter, toxic to skin, mucosa, carcinogenic. So daily preparation may cause corrosive damages to the fabrics, carpets. Third type is the low level disinfectant. It destroys all the vegetative and enveloped viruses. Other actions is invariable. So example, quaternary ammonium compounds. So mechanism is by producing enzymes, denaturation of the cell proteins and cell membrane. The preparations are the benzyl ammonium chloride, but it is not acting in presence of hard water. But newer generation quaternary ammonium compounds are active in hard water and better compatible. Cleaning agent. So cleaning is important step for the before disinfectants applied to remove organic matter, because few reagents do not act in the presence of organic matter. So the examples are enzymatic cleaners. So they contain enzymes like amylase, lipase and protease and all. Cleaning chemicals, so they are detergents. So manual cleaning and automatic mechanical cleaning like ultrasonic washers, disinfectors. Test for chemical disinfectants to check the efficacy, potency of the disinfectants. So the various methods are available. So first is a Riddle-Walker or phenol coefficient test. Second is the Chick-Martin test. Third is the capacity, that is Kelsey-Sykes test. And fourth is the in use, that is Kelsey-Maurer test. Ethylene oxide or ETO sterilizer most commonly used in the CSSD. Mechanism is microbicidal, where it causes disruption of all the cell components, that is cell proteins, DNA and RNA. The sterilization cycle you have to carry out in the 3 stages. So first preconditioning, then sterilization and then aeration. Preconditioning, air is replaced by the vacuum. Sterilization, ETO is allowed in the chamber, so gas concentration, temperature, humidity, exposure time should be noted. Then aeration, that is degassing, so extensive aeration to remove residual ETO, because ETO is a toxic and carcinogenic. The uses used by CSSD to sterilize critical items, sometimes semi-critical items that are moisture or heat sensitive and cannot be sterilized by steam sterilization. So examples: heart-lung machine, components, sutures, catheters, stents, respirators and dental equipment. Advantages: suitable for the heat sensitive items. It has high penetration power highly diffusible, penetrates areas that cannot be reached by the steam, non-corrosive to plastic, metal and rubber material. Disadvantages: highly inflammable, irritant, explosive and carcinogenic. So ETO is usually supplied in 10 to 20% concentration mixed with inert gases like either CO2. The long duration of cycle 12 to 14 hours. High cost of instrument and consumable. Sterilization control: spores of Bacillus atrophius is the biological indicator. Second is the plasma sterilization. So it is a gaseous state consisting of ions, photons and electrons and free radicals such as O and OH. So it is the most commonly used device in the CSSD to create plasma state. So process: first vacuum is created, then second chemical sterilant, that is H22, is vaporized for 50 minutes at low temperature 37 to 44 degrees Celsius. Then gas plasma is produced by the applying electric field. Last step: excess gas is removed. No aeration required because byproducts are not toxic. Cycle duration 75 minutes. Uses by CSSD for sterilization of materials and devices that cannot be tolerating the high temperature and humidity of steam sterilizer. Example: plastics, electrical devices, corrosion susceptible metals such as arthroscope. Precautions or disadvantages: so my item should be dried before loading. Then linen or paper or cellulose liquid cannot be processed, may not penetrate well, especially in channels or devices for long lumen. Has small chamber, cannot be used for bulky amounts, expensive equipment and packing materials. Sterilization control is the biological indicator: spores of Bacillus thermophilus. So these charts suggest the summary of the all disinfectants. So glutaraldehyde, Sidex aldehyde type 2%, mostly for the sterilization of all the scopes. Povidone iodine, halogen group 2 to 10%. It is used mostly as an antiseptic, wound clinic and mouthwash. Dettol, phenolics group, mostly antiseptic for the wound. Hypochlorite, so it is 1 to 5%, mostly 1% hand washing, 4% disinfectant. Hydrogen peroxide, oxidizing agent, 3 to 5%, disinfection of the wound and environmental surfaces, mainly used for the fogging. Formalin aldehyde group 10%, preservation of anatomical and histopathology specimens. Phenol carbolic acid 5%, disinfection of environmental surfaces, floor, walls, disinfection of the sputum, skin, antiseptic.
Hello students, welcome to this session. So today we will study CSSD, that is Central Sterile Supply Department. So this is very important component of the hospital premises. So there are total 4 unidirectional zones, that is from unsterile to sterile, that is single direction. So first is decontamination area. So items collected and decontaminated by manual wash or automated machines like ultrasonic washer. Then packaging area, medical devices are enclosed in containers to protect device from contamination and damage during sterilization. Then sterilization area, so packed medical devices are subjected to sterilization like steam sterilizer, ETO or plasma sterilizer. Then sterile storage area, so sterilized items are stored. It has issue counter to supply items to operation theatre and other part of the hospital like ICU wards. So the definition is the service responsible for receiving, storing, processing, distributing and controlling the professional supplies and equipments, both sterile and non-sterile, for all user unit of hospital for the care and safety of patient under strict quality control. So this is the definition of the CSSD. The objectives and functions: to provide sterilized material contributing to a reduction in the incidence of hospital infection, to avoid duplication of costly equipment, to maintain record of effectiveness of cleaning, disinfection and sterilization process. So the structure in short, so there are total 3 zones: protective zone, clean zone and sterile zone. So protective zone includes receiving window, cleaning area, decontamination area, drying area and assembling and packaging area. Then clean zone includes autoclaving area. Sterile zone includes sterile storage room and issuing window. So here you can see in detail protective zone. So first is receiving area. So items are brought to CSSD from different wards, ICU, operation theaters. Then cleaning area. So in this area all instruments are primarily cleaned, rinsed with plain water to remove visible particles. Then decontamination area. So here you can use the decontamination by glutaraldehyde or enzyme solutions. Then drying area, then assembling and packaging area, then packing area. In this section various types of dressings like gauze pieces, cotton pads and bandages are also prepared in this area. Then in clean zone, that is autoclaving area. So autoclave is the method of sterilization, and then for the 30 minutes we can do that cycle. Then sterile zone, in that sterile storage area, so the sterile items are stored in here, and issuing window, so from here you can distribute these sterile items. So monitoring of autoclave is very important. So temperature, pressure, time, that is temperature is 121 degrees Celsius, pressure is 15 lbs and time is 15 to 20 minutes is important. So here you can see these are different zones. So the first is transport used materials coming to the CSSD, then transport, then going for the cleaning, then disinfection, then inspection, then tray are assembled, they are packed, then sterilization is done, and then sterile storage area is there, and then they are transported to the operation theatre or ICUs or wards wherever required. So these are all the sterile items storage area. So total 10 areas are there. So first is break room, then changing room, then receiving area, dirty area for cleaning, then inspection, assembly and packaging area. Sixth is decontamination or sterilization area. Seventh is store room. Then 8 is clean area for storage of sterilized packs. 9 is dispatch, and 10 is clean store area. So these are different areas. Here you can see break room, changing room, receiving area, dirty area, inspection, assembly, packaging area, decontamination and other areas, clean storage area, then dispatch area. So proper decontamination process. So where appropriate, personal protective equipments like gloves, apron, face mask, cap during decontamination process. Don't pre-soak instruments. Make sure dedicated area is available for the decontamination, and then follow it by standard SOPs. Then you can their regular monitoring of the temperature, humidity control should be there, and then there should be sink for hand washing. Provide suitable education and training to the staff. So cleaning protocol of CSSD, environmental surveillance is done monthly basis to check the air quality of sterile zone. Floor is mopped daily with soap and water. Fogging of sterile storage room may be done. Then trolleys, shelves and tables are wiped with disinfectant every day. So in recall policy, action to be taken if any monitoring indicators fail. So recall the item immediately with the help of load chamber. CSSD supervisor are informed immediately. Then CSSD personnel should try and discover the cause of failure and arrange for corrective action, and items are reprocessed and then supplied after confirmation of the sterility, and record should be maintained properly. Hello students, today we will see biomedical waste. So its definition, rules of 2016, the types of biomedical waste and its hazards associated with the biomedical waste. So according to Biomedical Waste Rule 2016 of India, biomedical waste defined as waste that is generated during laboratory diagnosis or treatment or immunization of human being or animal, or in research activities or in production of biologicals. So that is called biomedical waste according to the rules of 2016 of India. Now, aim of waste management to prevent harm resulting from waste, to minimize its volume, to retrieve reusable materials from the waste, then to ensure safe and economical disposal methods, and last to protect health and well-being of patients, staff and public. So what are the steps for this waste management? So first is the reduction. So proper planning so that the waste volume should not increase. So main first step is the reduction of the biomedical waste. Then after that, whatever waste is covered, so you have to recover that. So reuse. So proper planning of the reuse of the waste produced. Then segregation. So at the point of generation, the waste should be segregated into different color coded bags. Then proper storage, then transportation to the central unit, then treatment, that is procedures and process to reduce bulk of waste and make it non-infectious and harmless. So these are the steps of waste management. So what is waste hierarchy? So in that all R are there. So prevent and reduce, that is production of waste is prevented or reduced to minimize quantity of waste. Then reuse and recycle. So plastic material should be recycled. So whatever reuse and recycle possible from the waste produced, that we should allow. Then recover. So energy recovery, that is waste is converted to fuel for electricity, or composting of organic waste to produce compost used in agriculture. So that is recovery of the waste. So to make it useful from the non-useful waste. Then treat. So whatever now leftover waste that cannot be reduced, cannot be reused, cannot be recovered should be treated properly to prevent health hazards. So the treatment example like incineration or autoclave, and then disposal. So that should be disposed properly in landfill or dump yard so that public or society should not get harm from that waste. So the waste are divided into two types, non-hazardous waste and hazardous waste. So non-hazardous is harmless waste, that is general public waste, that is kitchen waste, or we can see waste from the leaves or plants. Then hazardous waste is infectious and non-infectious. So infectious waste is biomedical waste, that is hospital waste, and non-infectious hazardous waste may be chemical, radioactive, pharmacological or cytotoxic. So now we will see according to the WHO classification there are few categories. So first is general waste. So it is no risk to human health. Example, office paper, wrapper, kitchen waste, general sweeping waste. Then pathological waste. So whatever waste generated in the pathological laboratory like blood and other samples, body fluids. Then sharps. So it can be needles, scalpel, knives, blades. Then infectious waste which may transmit bacterial, viral, parasitic diseases to human beings, and waste suspected to contain pathogen. Example, laboratory culture, tissues, then bandages, dressings if they are infected. Then chemical waste, so it is laboratory reagent or disinfectants used. Then radioactive waste, it is unused liquid from radiotherapy or lab research, contaminated glasswares while doing investigations. So this chart will show you the category and the treatment method. So biomedical waste management, first is segregation of waste, then collection of biomedical waste, then transportation to the central unit, then treatment of the hospital waste. For the solid waste it can be incineration or autoclaving. For liquid waste it can be disinfection. So human or animal waste or soiled waste can give infections like HIV, hepatitis B, hepatitis C, hemorrhagic fevers, cholera, salmonella infection, shigella infection, then rabies, leptospirosis, anthrax, tuberculosis, pneumonia, septicemia. So these are all associated with the human or animal waste or infected waste. Then sharps can transmit infections like HIV, hepatitis B and hepatitis C. Then cytotoxic or radioactive waste can cause cancer, genetic mutation, or birth defects. Then chemical waste can cause poisoning, dermatitis, conjunctivitis, bronchitis. So there may be health hazards like psychological stress, infectious or diseases, or injuries, cancer, genetic mutation, birth defects, poisoning. So all these are associated with the hazards of the. So what are the different types of waste generated in the hospital? So they are solid waste, liquid waste, biomedical waste, chemical waste, radioactive waste. So different types of waste generated are these. So we will see in detail. So it can be category 1, that is human anatomical waste like blood and blood products, placenta, removed tumors, other surgically removed body parts like appendix, uterus, or biopsy materials, excreta. Then category 2, it is animal waste. Category 3, microbiology and biotechnical waste like culture media and plates, vaccine waste, reagents used in microbiological laboratory studies. Then category 4, it is sharp waste, that is needles, syringes, scalpels, glass beads, broken ampules. Then category 5 is discarded medicine and cytotoxic drugs. Then category 6, soiled waste like cotton dressings, plaster cast, soiled beddings, linen, clothes, mask. Then category 7 is solid waste like plastic waste like IV sets, tubings, catheters. Category 8, that is liquid waste, which are reagents used in the hospital. Then category 9, it is an incineration incineration ash. And then category 10 is chemicals. So the yellow bag, it is a non-chlorinated plastic bag, and separate collection system leading to effluent treatment system should be there for the chemical liquid waste. So this yellow bag contains human anatomical waste, expired discarded medicines, then chemical waste, microbiology and biotechnical clinical lab waste material. And treatment or disposal method is the incineration, plasma pyrolysis, or deep burial. Then red color bag, it is non-chlorinated plastic bag or container, and here mainly it is recyclable contaminated material is there like tubings, bottles, IV sets, tubes, catheters, urine bags, syringes without needles, and glues. So the treatment method or disposal method, it can be autoclave, microwave, hydro processing, or recycling, and then to the landfill. Then white color translucent puncture leak proof container. So mainly it contains waste sharps including metals, and then method of the disposal is autoclave or dry heat sterilization, then shredding of that or mutilation, and then encapsulation for the reuse. Then blue color contains, it is a cardboard box with blue colored marking. So type of waste, mainly it is broken glass waste, slides, cover slips, or pipettes, or ampules without medicines. And then treatment, it can be disinfection, autoclave, microwave, and then recycling should be done. So there are steps we already saw. So first is segregation, then transport to site of temporary storage, and then final disposal. So segregation, the staff is provided with personal protective equipments. Then segregation is done at source where the waste is generated. Then color coded waste bags are placed in bins in all patient care areas. Labeling of all the bags with pre-designated labels with information including hospital name, patient care, unit name, and date is done before use of bags. So transportation, waste from various patient care areas is removed twice a day or more frequently if necessary. All bags are tied at the mouth to avoid spillage during transport. Avoid the transport of too many bags at one time. Avoid contact of the bag with the body of personnel. Mixing of segregated waste should never be done, and biomedical waste bags should be sent to disposal when it is 3/4 fill. So these are all the points to be considered while transportation of the waste. Now disposal methods. So first is chemical disposal, the chemical disinfection. So for sputum, pus samples or body fluids, blood, urine, stool, all they are done by chemical disinfection. So 1 to 2% sodium hypochlorite solution is used for the chemical disinfection. Then deep burial. So material after disinfection put into deep trenches covered with lime and filled with soil. So this is mainly done for shafts. Incineration. Solid infectious waste, anatomical waste under high heat converted into ash. So incineration is done by using high heat, that is burning, and then it is converted into ash. The disadvantage of this incineration is for the plastic, because of the plastic they under high heat they give form black smoke. So that is carbon monoxide production, and that is injurious to the health. So plastic items should not be incinerated. Then autoclaving can be done for infectious waste. Then microwave for small volume infectious waste. Then ETP, effluent treatment plant. So liquid waste treated with disinfectant. So liquid waste which is generated in the hospital, it is treated with the disinfectant, and then neutralization is done and then flushed into the sewer system. So that is ETP, effluent treatment plant. And then mechanical pressure shredder. So all glass waste or plastic waste should be mechanically broken down into small pieces, and then they can be reused. So liquid waste pre-treatment should be done, 1 to 2% sodium hypochlorite used, and then ETP plant to remove suspended solids and organic matter, and then drainage system of hospital should be connected with ETP and outlet of ETT connected with the municipal drainage. So this is these are the disposal methods. Solid waste management. So composting by microorganisms and vermicomposting by earthworms, or landfilling for disposal of non-biodegradable waste. Sanitary landfill, open backyard, it is not acceptable, and recycling can be done. So biodegradable waste degraded by microorganism into simple compost, example paper or food material. Non-biodegradable waste non-degraded by microorganism, example plastic, aluminum cans, so they are recyclable. Now advantages and disadvantages. So landfill is a cheap, land can be reused once the site is full, can be used to deal with large volumes of waste. But the disadvantage, toxic chemicals can be produced, heavy metal ions can leak into the ground, non-biodegradable plastics may not be broken down, and it occupies large area. So that is a disadvantage of the landfill. In special situations like metal sharp, so needle cutter or burner for cutting or burning needles can be used, like blades, needles, scalpels. They are placed in white container and then it is sent to the central unit. Then glassware, pre-treatment with 1% sodium hypochlorite for 20 minutes, and then broken slides, test tubes stored in blue color puncture proof container. Vials, ampoules can be used put in a blue color puncture proof container.
Let's study disease control guidelines in Hicp.
Now we will see outbreak definition. So it is a occurrence of two or more epidemiologically related infections caused by organism of same type relating to place and time is defined as outbreak. So there are main two types of the outbreak. One is common source outbreak and second is propagated outbreak. So in common source outbreak, there is a common source, so like contaminated food or water. So in that subtypes are one, point source outbreak, so it is of short duration, example food poisoning in the party. Or second is continuous common source outbreak, so it is of long duration, example contaminated water supply from tap water or from well. Then third is intermittent common source outbreak, so it is intermittent exposure, example industrial contamination. And the second main type is propagated outbreak, so there is no common source in that and the outbreak spreads from person to person and then it causes epidemic. Now we will see steps of the outbreak investigation. So there are total 13 steps. So in step 1 you have to prepare for field work. So confirmation and verification of the diagnosis is there. Then second step, recognize the outbreak and prepare to investigate. So establish existence of outbreak, determine if immediate control measures are needed, then notify and communicate, and formation of outbreak control team. Then step 3, verify diagnosis and confirm the outbreak exists. Step 4, construct a working case definition. Step 5, find cases systematically and record information. Step 6, perform descriptive epidemiology with respect to time, place and person. Step 7, develop hypothesis. Step 8, evaluate hypothesis epidemiologically. Step 9, reconsider, refine and re-evaluate hypothesis. Step 10, compare with other lab or environmental studies. Step 11, implement infection control measures. Step 12, initiate or maintain surveillance. Step 13, communicate findings. So communicate in the hospital or prepare the final report. So in post exposure management there are few steps. So first step is first aid. So then second is report to designated nodal center. Third is take first dose of PEP for HIV. Then lab testing for bloodborne viruses. Then decision on PEP for HIV and hepatitis B. Documentation and recording of exposure. Informed consent and counseling. Follow-up testing and precautions during follow-up period. What do we mean by exposure? So it is exposure to the blood or body fluids because of the injury by injections or catheters or any sharp object like scalpel or forceps. So let's see one by one. So first is first aid. So what to be done and what to not to do. So first in do's, so for sharp injury, immediately wash the wound and surrounding skin with soap and water followed by thorough rinse. For splash, irrigate the site thoroughly with water at least for 5 minutes. In do not panic, do not place the pricked finger into the mouth, do not squeeze blood from the wound, do not use antiseptics and detergents. Second is report immediately to the designated nodal center. So report to the duty casualty medical officer CMO. Then evaluation of exposure risk. Provide PEP, that is antiretroviral therapy for HIV, for hepatitis B virus vaccine or immunoglobulin. Then facilitate laboratory testing for hepatitis B, HCV and HIV. Then maintain the record of needle stick injury. Then third is first dose of PEP. It should be taken as early as possible. Maximum effect will be there if it is taken within 2 hours of the exposure. Then recommended PEP by NACO is single tablet of tenofovir 300 mg plus lamivudine 300 mg. If source HIV test report is documented and is negative, then no need for the first dose of PEP. Then fourth is testing for bloodborne viruses, done for both healthcare worker and for the patient, that is source. It should be done by rapid methods. The tests done are anti-HIV antibody detection by tri-dot method usually, then hepatitis B antigen detection test, then anti-HCV antibody detection. Anti-HBs antibody is done for healthcare worker if previously vaccinated. The decision on post-exposure prophylaxis. So for HIV, it depends on the type of exposure like mild, moderate, severe and HIV status of the source. And for hepatitis B, it depends on the hepatitis B vaccination status and protective antibody titer of healthcare worker and hepatitis antigen status, positive or negative, of the source. So this is a chart showing in exposure code and source code. So if the exposure code 123 and source code negative, then PEP is not recommended. If exposure code 1 and source code 1, then also PEP not recommended. Exposure code 1, source code 2, PEP required, that is tenofovir 300 mg and lamivudine 300 for 28 days. Exposure code 2, source code 1, PEP required for 28 days. Exposure code 2 and source code 2, PEP required, tenofovir 300, lamivudine 300 for 28 days. exposure code 3, source code 1 or 2, PEP required. Exposure code 2 or 3 and source code unknown, PEP required. For hepatitis B, if healthcare worker has taken 3 doses, then it is not required. If non-responders after 6 doses, then you have to do hepatitis B surface antigen test, and then hepatitis immunoglobulin 2 doses are required. For 3 doses of vaccine, hepatitis B test positive but anti-HBsAg antibody test less than 10, then hepatitis B immunoglobulin 1 and revaccinate. If antibody test is less than 10 titer and HBsAg negative, then no need of immunoglobulin or vaccine. If antigen test is plus minus and antibody titer more than 10, then no need of the immunoglobulin or vaccine. In unvaccinated, HBsAg positive but titer is negative, then immunoglobulin 1 dose and complete vaccine schedule, that is 016 to be taken. If the test negative, anti-HBs antibody negative, so no need of immunoglobulin but complete vaccine, that is 016 to be taken. Then sixth step is documentation and recording of the exposure. So structured form pro forma is there for collection of detailed information: date, time, place of the exposure, type of procedure done, type of exposure, duration of exposure, exposure source and volume, type of specimen involved. Then seventh step is informed consent and counseling. So to relieve anxiety of exposure, to inform about risk and benefits of PEP, the exposed person must sign a consent form for prophylaxis treatment. Then eighth step is follow-up testing. It is necessary if the source is positive or unknown. Clinical follow-up, monitoring for development of signs indicating HIV seroconversion, usually within 3 to 6 weeks after the exposure. Laboratory follow-up for HIV testing, follow-up at 6 weeks, 3 months and 6 months. For HBV and HCV, 6 months after the exposure. Liver function test at baseline, start of PEP for HIV. Complete blood count and hemoglobin estimation baseline should be done then at the end of the second and fourth week of the PEP for HIV. Precautions during follow-up period. So refraining from blood organ semen donation, should not donate any organ or blood or semen. Then safe sexual practices till both baseline and 3 months HIV tests are found to be negative. Then seek medical evaluation for any febrile illness that occur within 12 weeks of the exposure. So reduction of transmission of hepatitis B virus from healthcare worker to patients by more vigilant screening of hepatitis B virus in healthcare workers, then hepatitis B virus vaccination in healthcare workers, practice of standard precautions, restrictions of practice of infected healthcare worker from exposure prone procedures, and awareness of healthcare worker to avoid EPP, that is exposure prone procedures. So if hepatitis B positive healthcare worker is there, then according to CDC guidelines 2012, what are the things to be done? So first, no restraining from the work. So he can come for the job, but then what precaution he has to take? So standard precautions like wearing of gloves, apron, mask, cap, and then plastic sheet, apron. Then use safe needle device, example blunt needles. So he has to use blunt needles. Then personal protective equipments like double gloves he should wear. Then avoid unnecessary phlebotomies. Then avoid unnecessary intravenous catheters. Cover exudative lesion till it gets resolved. So if he is having any exudative lesion, any discharging abscess or sinus, then it should be covered. Then investigations for infectivity, that is hepatitis B virus DNA and HBe antigen testing should be done for the infectivity status. Then the expert review panel, so evaluate positive healthcare worker clinically and by viral load, assess practices and procedures, then counseling of exposure prone procedures and advise precautions to be followed. So these are the things we have to do according to CDC guidelines 2012 for the hepatitis B positive healthcare worker. So in this chart we will see if the viral load, that is hepatitis V, the hepatitis virus B virus DNA, if it is less than 1000 and if it is more than 1000, so what to be done. So if the hepatitis B virus DNA is less than 1000, so that healthcare worker can perform exposure prone procedures category 1 and 2. So now we will see what is 1. So in category 1, these are the high risk procedures. So major surgeries, major injuries like hysterectomy, delivery, LSCS, vaginal delivery, oral surgery can be performed. If hepatitis B viral DNA load is more than 1000, then can perform exposure prone procedures category number 2. So now we will see what is the things can be done in category number 2. So these are low risk procedures. So other surgeries other than major surgeries, then use of needles when hands are outside the body, then phlebotomy like phlebotomy, IV lines, medication by injections. So in that hands are outside the body. Needle biopsies, lumbar puncture, minor dental procedures, insertion of tubes, endoscopy, internal examination with gloved hands, that is vaginal, oral or rectal, then external examination like temperature, pulse, blood pressure, respiratory rate, eye examination can be done. So in less than 1000 the load of the hepatitis B virus can perform both the categories procedures, that is high risk and low risk, and if the more than 1000 is there, then category number 1 is not advised, so only category number 2, that is low risk procedures can be done.
Antibiotic stewardship provides strategies for rationalizing the use of antimicrobials in the hospital. CDC has defined antimicrobial stewardship as the right antibiotic for the right patient at the right time with the right dose and right route, causing least harm to the patient and future patients. Indian statistics on antimicrobial resistance due to absence of central monitoring agency. Indian statistics on antimicrobial resistance not clear except for M. tuberculosis and leishmania. Antibacterial resistance to S. pneumoniae is now a global problem. In India, the strains are still sensitive to penicillins, macrolides, and fluoroquinolones. Multi-drug resistant enterobacteriaceae are common. Consequences of antibacterial resistance, serious complications for elderly and children, compromised therapy of human infections, increased length of therapy and more doctor visits, prolonged hospital stay, and significant increase of treatment cost. Bacterial resistance is a major threat to public health. Inappropriate antimicrobial use, lack of quality control in manufacturer or outdated antimicrobial, inadequate surveillance or defective susceptibility assays, poverty or war, use of antibiotics in foods, see antibiotics for viral infections, antibiotics sold without medical supervision, spread of resistant microbes in hospitals due to lack of hygiene. Control of resistant bacteria. Do not indulge patient demands for unneeded AMA. Educate patient on appropriated AMA use. Identify the pathogen. Choose appropriate duration and spectrum AMA, combination therapy, complete full course of therapy, use AMA prophylaxis prudently, follow proper hygiene during procedures, search for the source or cause of spreading of infection, encourage patient to get vaccinated, improve resistance surveillance systems, use antibiotics judiciously in non-human settings, advocate new drug development, gene therapy, query, antibiotic policy, and monitoring antibiotic use in hospitals, restricting use of third and fourth generation antibiotics, rational empiric therapy based on susceptibility data from microbiology hospital, implementing antibiotic stewardship in critical care units.
So Hospital Infection Control Committee is constituted to plan, monitor, evaluate, update and educate healthcare worker on standard infection control practices. The scope of this is 1. The meet periodically to evaluate infection rate in hospital. Second, monitor infection control practices. Third, look at infrastructural corrections required to prevent spread of infection. And fourth is the detect hospital outbreaks of infection. The components of HICC: first is medical superintendent, second is medical MD in microbiology, then third is ICN, that is infection control nurse. So the function of this infection control nurse to visit all areas of patient care like operation theatre, CSSD, laundry, biomedical waste to monitor practices. Then the next component is head of surgery, head of medicine, then head of housekeeping, head of kitchen to prevent foodborne infection outbreak. So infection control officer is a MD microbiologist, and just now we already saw the role of the microbiologist. So these are the duties of the infection control officer. So the duty is to communicate, coordinate, then keep the track of developing outbreaks, and then participate in research activities, and main developing the guidelines for appropriate collection, transport and handling of the specimens, then laboratory safe practices, perform antimicrobial susceptibility testing, and then giving the summary report of the antibiotics, and monitoring of sterilization, disinfection and environment practice is wherever necessary. So these are the main duties of the infection control officer. So the selection of infection control nurse is selected through the following process. So any staff nurse who can volunteer to enroll for ICN, or nominated nursing staff can be enrolled, or all staff nurses have to undergo written exam provided by surveillance and infection control division, and only staff nurses scoring more than 90% of marks shall be enrolled as ICN. So according to the hospitals, there are different selection criterias. Now we will see what are the definition of infection control nurse. So this ICN is a registered nurse with additional academic education and practical training in infection control, clinical and diagnostic microbiology, epidemiology and computer technology. So the duties to the ICN is a bridge between HICC and wards and ICU. So the ICN should go on rounds and visits all hospital location, control and monitors these healthcare workers for the infection control measures, then identifies the problems and implements appropriate measures, then collection for healthcare hospital acquired infection surveillance, hand hygiene audit, then PPE audit by daily visiting, then implementation of transmission based precautions, disinfection policy, high risk areas environmental surveillance, education of healthcare workers and patients, provide post exposure prophylaxis for needle stick injuries and maintenance of the registers, then staff vaccination program for hepatitis B virus and influenza, and involved in antimicrobial stewardship activities. So these are the duties of the infection control nurse.
Hope you find this session useful for your understanding and for your exams. Thank you.